Welcome everybody. My name is Nicole Moran. This is the 8th session of today's conference. I will be your moderator for today's session. And I am the project officer at SN-INT Netherlands, and I'm delighted to be able to moderate this session today. I'm also joined by my colleague Charlotta, who will be our lovely tech host. Also joined by our 3 young researchers and our expert discussant Olgah. While we're waiting for everybody to filter in and doing the kind of opening words, I would invite you to introduce yourself in the chat. If you would like, tell us who you are, where you're joining us from, and maybe even what you are most looking forward to from today's session. So as I said, this is the final session of today's conference. So hopefully some of you have already been joining some of the sessions that have been happening beforehand. The conference is our annual Linking Research Policy and Practice conference, which is being organized this year by SN-INT International. For those of you who maybe aren't so familiar yet with SN-INT International, we are the international knowledge network on sexual and reproductive health and rights. We have country hubs in 7 countries, which include the Netherlands, Bangladesh, Burundi, Burkina Faso, Ethiopia, Colombia, and Jordan, as well as having many, many members from a number of different countries who belong under our international branch. This event traditionally brings together policymakers, practitioners, and young researchers working on SRHR, gender equality and women's empowerment in international development. The focus lies on the work of young professionals who have recently submitted or in the process of finishing research as part of their master's program, postgraduate degree, a research internship, or maybe even a research consultancy. The title of this session is Underexposed Perspectives, and it will look at SRHR topics which are more often neglected in SRHR research. And we will hear perspectives from Mali, Denmark, and Uganda, which is where our young researchers have focused their work. To kick off the session, we will have our first presentation from Margherita. And Margherita holds a Master of Science in Youth Education and Society from Utrecht University. And her presentation is titled SRHR and Malian Youth, a look from outside of health. So Maggie, over to you.
Yes, I will share my screen. Yeah, share. Perfect. Okay, perfect. So yes, as Nicole said, I am Margherita Magoga. I recently graduated from Utrecht University from a master program called Youth Education and Society, where my focus was specifically for international development. And today I will outline my main findings based on my thesis research on sexual and reproductive health and rights provisions and youth in Mali. So how is this issue relevant for Mali? Well, if we look, we can see that there are gaps in SRHR provisions and meeting people's needs. According to data from 2018, 52% of single sexually active women and 25% of women in a partnership have unmet needs for modern contraceptives. Furthermore, Mali has restrictive abortion laws that can have an influence on illegal abortion practices. And finally, the country has a high incidence of female genital mutilation. According to the Mali 2018 Demographic and Health Survey, 86% of women aged 15 to 49 years old underwent total or partial removal of the female external genitalia for cultural or non-medical reasons. Therefore, I've decided to investigate how Mali's socio-political context affects SRHR provisions aimed at young people, targeted specifically for contraception, abortion practices, and female genital mutilation. To do so, I decided to investigate on the cultural beliefs about gender and sexuality and on the country's effort to implement international treaties that it signed and ratified. I decided to base my research on the social determinants of health approach that Marmot and colleagues describe as the condition in which people are born, grow, live, work, and age. And according to the second principle, it is essential to tackle the inequitable distribution of power found within every country and focus on the structural determinants of health. In this case, I decided to focus on cultural factors and laws. So in order to answer my research question and the sub-questions, I decided to conduct interviews with experts of adolescence and SRHR in Mali. In addition, I also decided to do a policy document analysis where I compare the Maputo Protocol to the Loi SR, which is a local Malian law aimed at the protection and promotion of sexual and reproductive health amongst the population. Now I would like to give an overview of the main findings of my research, starting with the influence that culture can have on SRHR provisions. So first of all, when it comes to contraceptive use, there are two main issues that arise: the attitudes of health professionals and the limited knowledge about family planning. Culturally speaking, young people in Mali are expected to preserve their virginity until their wedding day, meaning that buying contraceptives, if you are in outside of marriage relationship at the local pharmacy, can be challenging and can result in negative judgment from providers. Moreover, one of the respondents explained that instead of going to a doctor and evaluate which contraceptive form would fit them better, young girls tend to use whichever one they can find without considering the possible side effects that can also sometimes include sterility. The situation around abortion practices can be very delicate. Culturally, abortion is something that is simply not done for two main reasons. It is perceived as murder, and the social stigma that arises from getting one and requesting one can be too much to handle. Even in cases where a young woman could legally ask for one, for instance, if she is a victim of rape or a victim of incest, having to provide proof that you were raped can bring to a process of shifting the blame from the perpetrator to the victim. And as a consequence, young girls prefer not getting one. Not undergoing female genital mutilation can have serious repercussions on a young Malian girl's life. One respondent explained that she will be considered as someone who is impure, infertile, or more drastically, as someone who that when giving birth could die and their child will not be able to be birthed. Furthermore, not being excised can harm a girl's chances to find a future husband, something that is considered of great importance in Malian culture. One of the research respondents also explained that there is still limited knowledge about the consequences of FGM. For instance, even though infertility is believed to be one of the side effects of not getting excised, it is actually one of the possible consequences of doing it. Therefore, women end up facing social stigma whether they do it or not. Now I would like to outline the main findings with regards to the legislative context in the country. First of all, in terms of contraceptive use, the Maputo Protocol and the Loi SR share some strong similarities. For instance, both documents promote family planning education for population, although in the case of the Loi SR, it has to happen within the respect of family moral values. In practice, there are different organizations across the country that help with the implementation of this article. The one organization that was mentioned the most was the Marie Stop Center, an NGO of SRHR specialists that helps young people understand better family planning and exactly how it works. When it comes to abortion practices, the articles concerned with it share some similarities. The main difference is that according to the national law, women can only request for an abortion if they are victims of incest and rape, and if their lives are in danger. That being said, there are several programs in the country that are aimed at the education of young girls on how to have a responsible sex life and the consequences that unwanted pregnancies and abortions can have. These programs also work with girls who are in vulnerable situation and at more risk of gender-based violence. One of the respondents pointed out that the programs take particular focus on education and try to keep girls in school for as long as possible so that they are not forced to rely on jobs that could expose them to an unsafe sex life. The biggest contrast between the two laws can be seen in the instance of FGM. On one hand, the Maputo Protocol dedicated an article to harmful cultural practices and calls for the complete abolishment of FGM. On the other, the Loi SR only mentions FGM briefly and states that SRHR care and services must include the treatment of consequences of excision. This means that there is, to a certain extent, the acknowledgement from the country that this practice can be harmful to young girls. That being said, in the past years, the country has mobilized to try and abolish the practice. This can be seen through the draft of a law against gender-based violence, where they also included the banning of FGM. Furthermore, the Ministry for the Promotion of the Woman, the Child, and the Family created the PNLE, which stands for le Plan National de Lutte contre l'Excision. It's a program aimed at the fight against FGM that strives for the development of a communication strategy to gather more supporters for the abolition of the practice, and also the inclusion of FGM in curricula for training schools for education and health professionals. Based on these results, there are different recommendations that can be made. Generally, I do urge NGOs to take into consideration the importance of including cultural values in future projects. For instance, including men in the adolescent SRHR talk is fundamental. In the case of Mali, men tend to have the ultimate decisive power on whether, for example, their daughters have to undergo the practice of FGM. Therefore, educating them about the consequences and risks of the practices is of extreme importance. Moreover, since the population is for the majority of Islamic faith and FGM is often associated with the Muslim religion, including Islamic religious leaders that do not condone FGM could help sensibilize the population about it. Secondly, SRHR policies at the governmental level should be made more accessible for the Malian population. Mali is home to different ethnicities, and even though the official language is French, around 80% of the population speaks Bambara as a lingua franca. Therefore, there should be an effort to ensure that information regarding policies concerning adolescent SRHR is accessible for everyone. Furthermore, sensibilization campaigns should strive to reach marginalized populations as well. For instance, internally displaced people, rural communities, or disabled young people. Lastly, health schools in the country should include specific training for healthcare professionals to help them distinguish between their personal value regarding adolescent SRHR and what their profession asks of them. This could help develop better attitudes toward young girls and boys that are seeking help and advice. To conclude, throughout this presentation, I've tried to show how the social political context of the country, in this case Mali, can influence health issues, in this case SRHR provisions for young people, aimed at contraception, abortions, and FGM. I would like to point out two fundamental elements of this research. First of all, even though I researched two separate structural determinants of health, they should not be considered so. Laws and culture are influence each other greatly, creating a domino effect. Policies and legislation are not much, if not rooted into the hearts and minds of the people to whom they apply. Secondly, although the issues outlined here might not be the same in other countries, there is still much work to do for adolescent SRHR in the global north and in the rest of the world in general, proving once more that in international development, there is no us versus them. Thank you very much for your attention. I want to leave you with my contact information. This is my personal email. You can write there if you need, or if you want to ask me any more specific question about research or just get in contact with me.
Brilliant, Margherita, thank you so much for your super insightful presentation, and the research sounds incredible. We were super fortunate that you were able to conduct it with us at KIT during your internship, so super nice. For those who maybe joined us a bit later, and if you have questions for Margherita, I'd ask that you post them in the chat. We will first hear from all our young researchers, and then at the end of the session, we'll have time for Q&A, so we can come back and revisit them. But I would really say if something pops up in your mind while you're listening to the presentations, just put them in the chat so we can come back to them. So moving on to our next young researcher, we have Mali O'Mara. Mali is from Ireland and has completed her BA at University College Utrecht and her Master's of Science at the University of Copenhagen. She's now graduated from her Global Health Masters and has submitted the paper that she will be discussing today for publication, so congratulations. Mali will also soon be starting a position as a migrant integration worker in Dublin in Ireland. Her research is titled Navigating Invisibility, an intersectional study of undocumented Nigerian sex workers' access to healthcare. So Molly, over to you.
Thank you. Thanks for having me today. I'm really excited to be here, and thanks to everyone who's joining to listen in. So yeah, you already mentioned the title, but so essentially I conducted this research with Carolina Elstead-Flink, who's not here today, unfortunately, but we did this for our master thesis, and yeah, we're working to get it published. So hopefully soon you'll be able to read the publication. And the title, once more, is Navigating Invisibility, an Intersectional Study of Undocumented Nigerian Sex Workers' Access to Healthcare. And I'll dive straight in, if I can go, there we go. So a little bit of background. Nigerians make up one of the largest nationalities migrating from Africa to Europe, and many of them do so in irregularity. Many make up a great proportion of those actually taking the treacherous central Mediterranean route. And there has been an increased risk there's been an increase witnessed in recent years with regards to the amount of women and girls traveling from Nigeria through the central Mediterranean route to reach European shores. And this has led to many tragedies, one such one in 2017 where there were 26 Nigerian women and girls' bodies found washed up on the shores of the Mediterranean. So there are a lot of Nigerians taking extremely dangerous routes to reach European shores. And lots of women coming from Nigeria who are undocumented in Europe end up working in sex work. And so these women experience increased health vulnerabilities, and there is very, very little known about the healthcare access that they have within Europe and within Denmark. And the reason why Denmark is such an interesting case to do such a study to look into the healthcare access of these women is because there's such a stark contrast between the progressive universal healthcare of legally recognized residents and those who are not recognized as residents, i.e. undocumented migrants. So within Denmark, actually, undocumented migrants are only entitled to emergency care, which is the bare minimum. And so there's a really great need for more research into undocumented migrants' access to healthcare within Denmark to lift the voices of these marginalized populations and to put pressure on the Danish government to change the current level of entitlements. So as I said before, this research is framed in intersectionality, as you can tell from the title. And essentially, intersectionality is a theory coined by Kimberly Crenshaw, which states that individuals' different social categories combine to create distinct experiences of oppression or privilege. And it's not about an addition or subtraction of different social categories. It's rather the intersection of these categories that shapes people's unique experiences. And this framework has been increasingly used in health research with marginalized groups. It's been hailed as a promising tool for understanding the complex needs of groups who fall through the cracks of healthcare systems. And it's actually been hailed as something that is really vital to the Leave No One Behind agenda in the SDGs. And so we embedded this framework into every point of our research, and it really shaped our findings. And as you can see here, these are the intersections of the women that were at the center of this study. So they were undocumented migrants, sex workers, street-based sex workers, Black Nigerians, and women. And this essentially shapes their access to healthcare. So briefly, the methodology that we used, we did participant observation in a night cafe for Nigerian sex workers and on the streets of the Copenhagen unofficial red light district. We also did 3 informal interviews with undocumented Nigerian sex workers, and we did 8 semi-structured in-depth interviews with different service providers working with this group in varying capacities. So there were social care workers, there were NGO nurses, NGO workers of different kinds, and volunteers. And so essentially, this was the final thematic network that we came up with. And as you can see right in the center is the invisibility of undocumented Nigerian workers. So what we found is that UNSWs, which is the abbreviation that we've used, their healthcare access is defined by their invisibility, and they navigate their access through that invisibility. And this severely inhibits their potential to prioritize healthcare and also fuels conflicting perceptions of their identities and healthcare needs amongst service providers. And so just a little bit about each theme. So the invisibility of undocumented Nigerian sex workers. Essentially, UNSWs are especially invisibilized due to their undocumented status and also exacerbated by their engagement in sex work. And so what I mean by this is that we actually found that their level of undocumentation varies in that some experience what we coined double undocumentation, in the sense that they both work and reside undocumented within Denmark. And because of Danish law, whether or not they're on a valid visa in Denmark, they're made illegal by their profession in sex work, as it's illegal for third country nationals to work as sex workers in Denmark. And they could be deported for this if that is found out, even if they're on a valid visa. So this intersection basically pushes them further into invisibility and makes it so that it's very hard for them to remain or it's very vital for them to remain unseen by the authorities. And then, however, at the same time, UNSW's ability to remain invisible is complicated, both firstly by their profession as sex workers, which relies on them to be visible to their clients on the streets of the red light district, and also by their racialized existence and the social assumptions which are inextricably tied to being Black women in the streets of the red light district late at night. And one service provider actually stated that this makes them visibly undocumented. And these two quotes here represent this theme very clearly. And so the first categorizing theme is that undocumented Nigerian sex workers have an inhibited potential to prioritize their own healthcare. And so the circumstances that they live and exist within in Denmark essentially makes it so that they don't have the privilege to prioritize their healthcare. And the first sub-theme of that is that they're in a thoroughly marginalized social position, which contributes to their experience of stigma and discrimination and makes them reluctant to seek health services and provides that barrier to their prioritization of healthcare. And a really good example of this comes from the first quote here. And this was recounted to us by a service provider we interviewed, who was called on the phone by a UNSW attempting to access emergency care at a hospital. And at the hospital, essentially, she was denied that care, which she was entitled to, because the secretary just told her, you can't come to Denmark and not make sure you have a medical card. That's your own business. And she denied her right to emergency care. So that is a very stark example of discrimination towards undocumented migrants in the healthcare system. And then on top of that, another element of this is the daily experiences of social insecurity that these women experience, which makes it hard for them to prioritize their healthcare, such as working the latest hours in the night of all sex workers and often encountering the most drunk and violent clients, which contributes to accounts of violence and rape of UNSWs, which we heard of, but this is hard to tackle because of their inability to report because of their status. And on top of that, they experience a constant threat of deportation, and they have no financial safety net, which makes it very difficult for them to take time off work, as you can see from the second quote on this slide, to prioritize their healthcare, I mean. And so then the last categorizing theme is conflicting perceptions of UNSWs. And essentially what this theme talks about is that because of their invisibility in Denmark, there's a lot of differing ideas of who these women are and what their needs are. And this extends to their healthcare access and the healthcare services offered to them. And within this theme, we coined the term positioned rationale, which was essentially used to describe how assumptions about UNSWs and their needs can at times inadvertently silence the voices of UNSWs further and lead to the creation of interventions which do not serve the women and can be potentially harmful. So one example of this is related to the first quote here, which was one service provider which we spoke with, and she spoke of the women in a way which diminished their ability to comprehend their own situation. and yet displayed great frustration over the lack of uptake of her organization's primary intervention, which was the repatriation of these women, which begs the question as to whether or not that was an intervention that actually served these women or somebody else. And then the second element of this theme is a much more positive one, which was that this research really testified that although UNSWs experience victimhood and vulnerability, their identity is not vulnerable. And throughout our research, UNSWs displayed their agency in healthcare in many, many ways, very often found ways to navigate the system, even though they experienced so many barriers. And one example of this was their eagerness to request condoms from us when we were walking on the streets at night, their utilization of their own network to access NGO health services primarily. And they reportedly found these services much before the services found them. And also utilizing alternative health-seeking behaviors to self-medicate and using NGO workers to facilitate their access to the formal system. So there was a lot of examples of them taking agency in their healthcare in whatever way they could. And this theme also highlighted examples of how some service providers work to encourage and facilitate agency in healthcare amongst UNSWs, and how that can increase UNSW's uptake of the services that they offer. And so, yeah, that's a very short overview of the findings. And then with regards to recommendations, I'm just going to talk about the more general international and then the Danish level. So on an international level, there is a really great need to visibilize global inequalities which produce irregular migration and cause UNSWs to migrate to Europe. And this is really the first step in changing the narrative on undocumented sex work migration. And it's central to increasing political will to improve the rights of UNSWs and other undocumented groups. But on top of that, there needs to be concrete steps to tackle the injustices leading to irregular migration. And we cannot look to securitization as a response to this. As I said at the beginning, people are taking the most dangerous and treacherous routes to reach European shores, and they continue to do so. And we need to look at the root causes of irregular migration, such as poverty and restrictive immigration laws, and really think about how we can work on those. And so on a Danish level, Denmark, like many other EU countries, has ratified human rights obligations, purporting that every individual has a right to the highest attainable standard of health. And at the same time, they're only offering emergency healthcare to undocumented migrants within their border. So the Danish state has a human rights obligation and a duty to increase the healthcare entitlements for undocumented migrants ASAP, because it is really an appalling situation currently. And on top of that, our study really highlighted that even though there is an entitlement to emergency care for undocumented migrants, that does not mean that it's accessible. And so Denmark has a duty to ensure the practicability of already existing entitlements for undocumented migrants in all of their diversity. So there's a need to recognize through this intersectional lens that different undocumented migrant groups experience different barriers to healthcare access, and the Danish state needs to find ways to overcome those barriers so that undocumented migrants can access emergency healthcare at the least. So that is a very brief overview. I hope you guys will actually read the paper because there's a lot more in it. But thank you so much for listening. And I want to express gratitude to all who contributed to the research, especially the participants. And yeah, thank you. I look forward to your questions and comments.
Brilliant. Thank you so much, Molly. And indeed, if anybody has questions, please do pop them in the chat so that when we have our Q&A and discussion section, that we can come back and ask our researchers these questions. So moving on to our last, but certainly not least, young researcher, we have Doreen Birungi, who will present her research to us. She holds a master's degree in public health that comes from the University of Ibadan. Doreen is a feminist who is passionate about male engagement work. She is a gender specialist at Sproutly Support Services, which is a consultancy firm that operates in East Africa and Nigeria. She is a member of a number of different initiatives, such as the Sexual Violence Research Initiative on their online community forum. She's a member of the Apolitical Forum, Young Feminist Hub, and also a member of China International. Doreen has authored 4 research working papers, all in the field of gender, and these have also been presented at international conferences. Today in this session, she will be presenting her research, which is titled Assessing the Opportunities /Pathways for Male Engagement in Family Planning Use, Communication Process and Decision-Making in Tororo District, Uganda during the 42 days of lockdown. Doreen, over to you.
Thank you very much, Nicolette, and thank you for this opportunity, SN-INT International. This is one of my first international conferences I'm attending, like concerning sexual reproductive health, because majority have been on gender-based violence. And then basically the research has been either in Nigeria, Uganda, but then this time I took time to write a paper with one of my lecturers from Makerere University, and one of them, the upcoming grassroots organization in Uganda. It's called Stuka Initiative. It's basically centered on working with men, because for the context of Uganda, many services don't involve men. Most of the services have involved women because they see that they've been neglected. Their rights, women's rights have not been achieved. Yes, they're in context of the policy making, documentation, but then the actual doing, like the actions are not yet out. So I'll go ahead and hope you're viewing my slides. So starting the introduction, I'll talk about male involvement in family planning. Basically, it looks at involving fathers, husbands, male community members. They might be your brothers in actively participating and decision-making for the women and supporting them to access services, basically sexual reproductive health. According to the context of Uganda, we see that we are from a patriarchal society where men are uplifted than the women, where we have looked at, the society has looked at men as the best stakeholders in decision-making. The women in some of the cultures, for example, among the Wagandas, among the Samias, and where I did my research in Tororo district, we see that men are the ones to make decisions. Women are to listen. They used to look at men as the active ones and the women as the inactive. But due to the coming of education, women empowerment, we have seen like organizations like Mifumi, organizations like UNFP, organizations like UN Women have come up to empower women so that they can be able to access services, even though the man can't make the decision or push her to the health center to access some of these services. But we see that in the context of Uganda, even like under Ministry of Health, we have grown up to know that sexual reproductive health services, it's not a right, it's all about a service. It's like family planning, because they're like the population is growing, so people need to involve into family planning, use condoms, contraceptives, and the rest of the different family plannings. But in our society, it was legal for a woman to come up and say, you know what, my dear husband, we need to reduce on the number of the children, because society, the patriarchal society, looked at children as a source of labor, could offer a lot of effort during like maybe farming and a different agriculture business they're doing. It looked at children as a pride, because a man who had several children, like 8 to 9, was looked at as a strong man, etc. I'll go ahead. In our study, we looked at the objectives. We aimed at investigating the pathways, opportunities for how we can engage men in supporting women in making decisions on family planning, not only at giving birth, escorting her to the hospital, but also reducing the number of the children according to their the society decisions, according to their income, earnings, and etc. Thirdly, one of the methodologies we looked at using qualitative studies, because qualitative studies are able to look at people's views, their ideas, and dominating, where quantitative looks at only the numbers. And this we picked some of the married men so that we can get to know from their perspective. Then we picked some of the individuals who are men and men who are just involved in a relationship, because they can still make decisions and say, let's only avoid getting pregnant. In case one is to conceive, either we can abort if you're not ready for to give birth, or we can involve in our other stakeholders. Then we also had interactions with the district health officers, because the DHO is majorly one of, let me say, like the decentralized system of Uganda. From Ministry of Health, we looked at the local government. So DHO office deals directly with the healthy facilities, than the government itself coming to the lower cadres to deal with them. So we're able to interact with some of the officials, and these were some of the people who were working during the COVID era, because not all health facility practitioners were able to access the healthy centers or even to interact with all of them. Then we looked at people who operate in the pharmacies, because most people get ashamed to access health centers because maybe a certain relative is working there, then a young lady maybe of 18 years is like, I want to use condoms because she's sexually active. You're like, no, I'll report it to your mother, I'll do this. So they prefer going to the pharmacy or the local clinics we have in the centers to buy the condoms and the contraceptives so that they can avoid conceiving when they're not ready. We'll move ahead to our findings. One of our major findings was the poor communication between the men, either the married one and married, just in a relationship with their female partners. And 49% of the men reported never discussing family planning issues. So it was the woman to go to the healthy center and ask, can I reduce on this? And it was secretive, so she could not tell the man. Maybe if she was swearing to conceiving, it's like, I think change of my cycle, but she wasn't able to discuss with a man because it was a taboo in the society, but it lines up to the patriarchal rules and norms in our society. So more than the 56 men we discussed with were our respondents. They said that never discussed with their wives, those who are married, among the married couples, that never discussed with their wives issues regarding family planning or use or anything concerning family planning. And later on, we gotten to know that they preferred even their elders like grandmothers, grandfathers to make decisions for them on issues of how many kids to have, either to use condoms and other different methods of family planning. Then limited access to healthy facilities during the lockdown, because we had 2 lockdowns. The first one was so terrible, but the second one was like a disaster because basically we're not allowed to move. And we had the advantage because we're working with an NGO, so it was easier for us to be permitted. But then we got to know that some of the respondents, we reached them at home, they were like, they cannot visit the family planning facilities, like the clinics, because the curfew time and limited movement. Then those who were able to access the facilities, they said some of the healthy practitioners were not trained to guide on which type of method should use, because some women were like, their hormones could react to different family planning uses. Then some families could not afford accessing the facility, like buying from the clinics and the rest, because they could not go and move the distances to the health facilities which have been established by the government. So they ended up conceiving and a lot of stress in the family. I'll move to my conclusion and recommendations. I'll conclude by saying that however much COVID-19 was able to affect on our communication costs and availability of healthy services, but there was no need for us to forget about sexual reproductive health, because as people are idle, most of the couples could engage in the sexual interaction than even doing other developmental issues. And the mere fact that some of the facilities, like the facilities were closed, some people are not even able to access their markets to pursue their economical earning activities and the rest. So majority involved into sexual activities, and they didn't know, even they were not aware of how to control the birth rate. So the burden comes back to the government and the other stakeholders. So I'll conclude by saying that the government and the other health facilities partners should advocate for a curriculum where we see that comprehensive sexual education is being implemented in our schools. For example, due to apart from the patriarchal society, but also the religious beliefs, they believe that it's a taboo for us to start talking about sex to kids who are like maybe 15. Should be a kid who is like maybe someone is above 18 years and above should be able to access such services, but you can't talk to a child who is like, according to our education system, maybe in P1 is like 6 years and you are like, I want to talk about sex. I want to talk about how you can avoid unwanted pregnancies, how you can stay in school. Yes, they give us ideas on how you can stay in school as a girl and control the birth rate, but how? They can't go into depth of introducing this. Of recent, Minister of Health and the Minister of Gender and Social Development and other civil organizations have been coming up to draw a line where they're working on the comprehensive curriculum, where they look at a framework being developed with the need of the religious or faith-based actors, but most of them have rejected, like from the Muslim society and the rest. They're like, no, it's a taboo. So it's still undergoing, but I would still call upon most of them to introduce this through social media so that people can be able to access this. Thank you very much.
Amazing. Thank you so much, Doreen, for your presentation and also for sharing your very insightful recommendations. And so for everybody attending, that is our final presentation from our young researchers. And so now we will dive into a plenary discussion where we will discuss what we've heard from Doreen, Molly and Maggie. And to help us kind of kickstart this discussion, we have invited Olgah Namukuza. And Olgah is here with us today in the role of an expert discussant. And so she will pose some questions to our presenters following their presentations. Maybe I can just introduce Olgah a bit to you all. So she is a public health specialist with a focus on sexual and reproductive health and rights for adolescents and young people. She's a former youth country coordinator for the SRHR Alliance in Uganda, in which her role was to ensure that the views and opinions of young people were heard and respected. And currently she works as a programs manager of the COVID-19 East Africa program. So Olgah, I'd like to hand it over to you and ask, what are your immediate reflections on hearing the presentations and the research from our researchers?
Well, thank you so much. Good evening to everyone. I hope that everyone is having a good evening. Well done to all of the researchers and the presentations. I think these are really different perspectives in terms of sexual and reproductive health and rights issues and how women are really affected in different ways. For me, when I was reading the abstracts and even when I'm listening to the presentations, I feel kind of sad. It saddens me that women are still going through these issues even at this time. It's even worse that women are going through the same issues across the whole country, because here we are having perspectives from Denmark, we are hearing perspectives from Uganda, we're hearing perspectives from Nigeria, but it is the same thing. We are seeing how culture is still affecting women's access to, sexual and reproductive health and rights information. We are seeing how religion and all of these other factors are playing a big role into how women actually utilize family planning and actually be able to use these services. So I think for me, it brings a certain light to all of us as international advocates to ask ourselves, are we really making a certain kind of impact? And that's what I wanted to ask with the researchers, for all of them to ask, is there something that is being done about the situation that you're talking about? I think Margherita in her presentation tried to put some light in terms of the policies that are available for FGM and also trying to see what the government is trying to do. But I wanted to ask particularly on that, if there are any particular laws that are targeting culture or how it really interplays into access to these FGMs, because I know like in Uganda, we have a law that is against FGM, but we have seen women who go and get the doctors to come and actually perform the procedure on them in the comfort of their own home. So you find that even when it is something that has been communicated as something that is really defying of women's bodies and their autonomy, you're finding that because of culture, women are still running back to that because that is what they were taught, that is what their culture is telling them. So I wanted to know whether in your perspective, there have been some laws that are really targeting culture and targeting the perpetrators of that and trying to see how that can be used to kind of unburden the women. And then when you mentioned something around the burden of proof when it comes to abortion, I think these are also similar thoughts when it comes to also what happens in Uganda. It really is unfortunate, but I wanted to ask around the consequences for accessing abortion care within Mali, because I know in Uganda it is very restricted. We only have certain consequences where it's putting the mother's health at risk. We also have circumstances where there was rape, and again it goes back to the burden of proof, and then also circumstances where there was incest. But you find that post-abortion care is provided, but abortion care by law is not provided in the country. So I wanted to know, in Mali, is this also the same, or is it different? I think I'd want to know something around that. And then moving on to navigating the invisibility, well done on this. And I think the first question that I wanted to ask was actually preempted by someone in the chat box to ask around, how are you able to have this kind of research as a white woman talking to Black women and Black sex workers, you know, at that? Because what we are seeing is that even within the marginalization, there is still another deeper marginalization, because it is one thing to be a woman and that's already marginalized. Then you're a Black woman, that's already another marginalized. Then you're an immigrant, then that's already another marginalized. Then, you know, it just keeps on getting deeper and deeper in terms of the issues that are marginalizing these women. So I wanted to know how you were able to navigate that and how you're able to get this positivity from them, and also something around, you know, the ability to seek services is one thing, and also to utilize the services another. But I just wanted to also, you know, speak to some of the issues around the injustices that are leading to migration in the first place, because, you know, some of these women are looking for greener pastures. You know, it's coming from a place of war in Nigeria where they were sent, but, you know, the Boko Haram is really, really, you know, hideous towards the women and girls. So I think it would be also important to understand what are some of these factors that are driving these women to these areas, and how can these be addressed as we are trying to address their issues of accessing to health. I think it would also be nice to also address their well-being and all of that, because it's also part of what drives them to these kind of dire circumstances where they have to go into sex work and they have to go into other, you know, forms of getting money. And then lastly, on male engagement, Doreen, I think that is a very great presentation. And also, before I move on to Doreen, I think it would also be nice to hear from Mali and also Margherita how COVID-19 has now, in a way, how COVID-19 has really played into these situations in the invisibility. How has now COVID-19, has it been worsened? Has there been, you know, a kind of flexibility in the healthcare system now that we are all looking out for each other and vaccination is going on for everyone? Or is this worse? And I think for also Mali, the same thing for Margherita, around how has COVID-19 really affected the situation of these people? And then Doreen, I think thank you so much for bringing in the perspective of the men and how they can be brought on as allies for women. I think as a feminist, broadly, this is a conversation that is always, you know, it's hot and cold at the same time, yeah? You know, because you want to bring in men into the conversation, but the question is, how do we bring in men into the conversation and still keep women as the priority of what we're trying to do? Because the examples, for instance, in Uganda, there was a policy where they were like, if a woman is coming to access antenatal services, she should come with her husband. And it comes from a good place where you're trying to involve men into, you know, services and making sure that they're also at the play of women to also access service. But you find that in the long run, if a woman doesn't have a husband, then she can't access the service. So then it becomes about the man again, and the woman who is actually supposed to access the service doesn't get it because the man, you know, something like that. So it's a double jeopardy, and I would like to hear your thoughts on how do we encourage this kind of conversation of having men as allies and partners, but still prioritizing women's health and ensuring that they're actually accessing and utilizing health. So thank you so much. Back to you, Nicole. I hope that wasn't a lot for you.
Brilliant. Thank you so much, Olga. And indeed, those are really, really interesting questions. I hope our presenters have written down I'm going to hand back over to Margherita, since you were first addressed, and maybe you can respond a bit to some of the questions that Olga's posed to you.
Yeah. So first of all, I have to say that I completely agree with what Olga said, that even though we're looking at different countries in the world, and even though we're looking at different cultural perspectives and different cultures in general, women definitely still face the same problems when it comes to SRHR and the reproductive rights. It is definitely something that I've also felt while doing the research. I was interviewing the different participants, and I also felt that a lot of the problems that they were facing in Mali, I felt they were also close to problems that I face, for example, when it comes to my country of origin, which is Italy. You know, for example, access to abortion in Italy, still 40% of doctors in the country refuse to provide that service, even though women are entitled to it legally. So as you, just to tie it to the first question that Olga had for me about FGM and the laws around it, and the cultural pressure that there is to go through with it. Yeah, in my research, I looked at FGM, yeah, from the Maputo Protocol and from what the local law in Mali said. And yeah, the problem comes to be that there is not really any legal document that abolishes this practice. The only thing that has been done as a step forward for Mali was the demedicalization of the practice. So doctors are not allowed anymore to practice it on patients. However, while I was doing research, I did encounter some articles that also went a bit more in depth with the problem of having a decriminalization of the practice, as you said, but still having a cultural pressure from women to still go through with it, and also from parents to still make their daughters go through with it. So it is definitely something that I recognize. It's definitely something that I agree with you. That's why also one of my recommendations towards the end was the importance of including cultural factors when it comes to issues like these, especially when it comes to making policies and to making laws. Simply saying that FGM should be criminalized does not work because of the cultural pressure. So that's why, for example, I talked about including Muslim religious leaders that do not condone the practice, that can help sensibilize populations about this, because they're seen as figures of respect from the population. People are comfortable talking to them. They're comfortable also asking them questions about such a sensitive topic that, for example, someone who comes from Europe like myself, they wouldn't feel so at ease about talking to me about these things, also because I'm not part of their culture and I don't understand the origins of this practice as much as someone who comes from there does. Oh yeah, and as I said before, like the Maputo Protocol is an international treaty that Mali has signed and ratified, and it does call for the complete abolishment of the practice, and it also calls for the aftercare component of it, where Mali should, for example, have centers where women can go and receive the appropriate type of nursing and the appropriate type of healthcare that they need in order to recover from such an invasive procedure done on their bodies. There are centers that help with that. For example, yeah, Marie Stop Center, it's the global NGO for SRHR issues. They do help with this. But yeah, I have to say at the governmental level right now, they are really trying to fight for this law against gender-based violence, where they also include the abolishment of the practice of FGM. However, they're receiving a lot of resistance from the population, from Muslim religious leaders that do promote it. And I have to say that also the current situation with Mali and their government, with it's not being very stable at the moment. In August of 2020, unfortunately, they suffered a coup d'etat that has left them without a government. That is still now, I believe, the situation. So they also have an internal conflict that is unfortunately taking over the state. And so when I was talking to my informants, to my respondents, I also tried to go a bit more in depth with that, and I saw that they also believe that sometimes the government tends to use the excuse of the instability as a way to not deal with these topics when it comes to SRHR. So I hope I've answered the first questions. With regard to the second question about abortion, so in the local Malian law, the loi SR, abortion is only accessible to women who are victims of rape or incest, are to women whose life is in danger. So it doesn't necessarily cover the life of the fetus, and it's very strictly only to these three elements that the woman has to meet. The difficult thing with abortion in Mali is that even though in the loi SR there are these three elements that a woman has to provide in order to access an abortion, the problem is that there's a penal code where it is still said, and it still has not been updated, where it still says that women cannot ask for abortions, and any doctor or any person who will perform an abortion on a woman can face severe legal consequences. So there is also this contrast in the country, and the problem is that people are not necessarily educated about it, and they're not educated about the loi SR, but they rather know the penal code. Moreover, the problem is also that instead of deciding to broaden the law on abortion, the government prefers to take this approach more as a family planning issue. So instead of giving more space to abortions and giving more space to women to ask for an abortion, they prefer to prevent abortions from happening. So for example, they prefer to have programs that work with girls, as I said, where they educate them about family planning, they educated them having safe sex, because they prefer preventing a pregnancy rather than dealing with the consequences of a woman being pregnant, and with the consequences that then will bring the country to having to broaden this law. That is something that they do not want to do. And respondent of mine who works at the governmental level, they work for the Dutch embassy in Mali. They also explained that, for example, early marriage in Mali still happens a lot because they prefer having an early pregnancy that is still within the scope of marriage, rather than having outside of marriage pregnancy, where women and young girls might be more keen to requesting an abortion. So also in that sense, this type of talks, like it's very complicated, and that's why also it is very important that cultural factors are featured when it comes to making new policies, when it comes to making new laws, because as we see, like, even though there are laws that allow women to ask for an abortion, even though there are laws then, or in other countries there are laws that allow women to not undergo FGM, there are still cultural factors that are pressuring these women to still undergo and be subject to them. Now, for the third question about COVID, I have to say that Mali, the cases are relatively low compared to the rest of the world. And when I was working with my respondents and when we were talking, the issue of COVID-19 never really came up. So it is not really something that I can answer. It's not really something that I know about, but I do believe that if it would have been an issue, maybe they would have talked about it, or they would have at least mentioned it. While I was working on my thesis, I was also working with my internship program, with KIT, together with a forest project that works directly in Mali. And the issues about COVID-19 were only in regards to, for example, having to organize workshops in real life for them in Mali, where we, of course, asked participants to wear masks or to have distance between them while they were participating in the workshops. But in detail when it comes to access to SRHR care and services. I do not know exactly to what extent this has been a problem for young women. But they have, for example, told me that people tend to not really trust, for example, getting vaccinated and trust the vaccinations, just like we see here in Europe. Also, other people do not do it. But I am not sure exactly to what extent it has prevented women or young girls from getting the help they need.
Yeah, brilliant, Margherita. Thank you so much for, again, super insightful answers. And I'm going to move on now to Molly. And I see that, Molly, your presentation has generated really quite some questions in the chat, which is super nice. So I would like to offer to you that either you can respond to Olga's questions directly, or maybe if you came across something in the chat that you maybe want to answer more directly first. I'm going to leave it up to you to answer what you feel like.
I'll start with Olga's, and I think there was a lot of other questions kind of relating to that, the first question that you asked, Olgah, which was about how I navigated this research as a white woman researching with Black women. And I think that's a really brilliant question. And I think it is, of course, a limitation to our study, but I think the way we navigated it was really just by trying to be constantly aware of our positionality in the interactions that we were having with these women. And I think the framework of intersectionality was actually a very good framework to do such research, because it's really a framework where you're constantly considering people's different social categories and identities and how they impact on your interaction with them as a researcher, and also, yeah, all of the findings and every element of the research process. So I think it helped, but I do think it's inevitably going to be a limitation always to be coming from a very different position. And then in relation to that, there was a question about sociocultural differences and how to navigate that. And again, I think it's really just a lot of like constant reflection and recognizing that there may be differing ways of communicating things, and differing, you might misunderstand certain things because of your different cultural background. But I think the solution to all of these is just trying to be constantly reflecting and aware of your own positionality and how that affects the research that you do. At least that's how I've tried to attempt to navigate these barriers. And then with regards to the next question, how to address issues pushing Nigerians to migrate irregularly, and are they being addressed? I think this is a really interesting question. And I think that the issue is that the way this problem is being addressed is completely unsustainable. There's this sort of idea that we need to repatriate these women because they obviously didn't come here on their own, with their own agency. That's kind of the discourse that's being put forward, that repatriation is the key. But we saw from our research and from talking to academics that again and again, these women just come back because they are making a living in Europe, and there is a pull to Europe to work in Europe. So the solutions right now are really unsustainable, and they're just shifting a problem away from the country that it's currently in, Denmark, for example. And so there needs to be, more tackling of root causes, there are a lot of studies that look into this, which claim that, there's lots of poverty, also violence, and also lack of career pathways for low-skilled workers and things like this that are pushing women from Nigeria to come and work in sex work in Europe. And there really needs to be a shift in the way we tackle this problem. And right now, I don't think there's much of that happening, at least in Denmark. From the context that I've studied, there is just really this constant discourse of repatriation or deportation. It's two of the same coin, really. It's like whether you're deemed a legal immigrant or a trafficking victim, the same solution is sort of what happens. One person goes back with a little bit of money, the other person goes back with none as a criminal. And so it's just a very unsustainable solution to the problem of irregular migration, sex work migration to Denmark. And so there were lots of other questions. I'm trying to think, what did I write down? So I think Nelson asked about the nationalities of the clients of the UNSWs. And we didn't really delve into that, but from what we understood, it's very, like, the demographics are wide, but nationalities we didn't look at. But I imagine a lot of Danish people from what I've seen on the streets, but there's probably a variety of nationalities, but I can't really comment to your question, unfortunately. And then somebody asked about changes in access to healthcare in the current climate with the migration policy in Denmark. And our study took place last year, and I think it was still the climate around migration was very heightened. So I can't really speak to the past, but I can say that from service providers we talked to, they sort of emphasized that there is this real sort of, what is the word I'm looking for? Like a filtering down of the political discourses around migration into the healthcare workers. And for example, that quote that I mentioned of the secretary saying, you shouldn't come to Denmark and not have a medical card, that's your own business. That was kind of a clear example of this really anti-immigrant sentiment, which is trickling into the healthcare sector, which is causing barriers to access for this cohort. So I do think that the climate around migration policy in Denmark is having a strong impact on migrants' access to healthcare. And we also saw that, like, with the NGO clinics that were targeting migrants, they often had to exist in extended invisibility. This was another part which I didn't bring into this presentation, but essentially those who work with undocumented migrants are also in this very liminal state, in this sort of invisible state, because they can't advertise their services because they're afraid that if they advertise too loudly, they may be shut down by the government, because what they're doing is sort of in between the law, because legally that all they can access is emergency care as undocumented migrants. So definitely the climate around migration has a huge impact on access to healthcare. And I'm not sure if there were more questions. Does anyone want to just ask them out loud if I missed some, because I got a bit lost in the chat.
I think if there are, that maybe you can just reply in the chat,
okay.
And we can hand over maybe to Doreen if she would like to also respond to what Olga has pointed out.
Thank you very much. I will start by saying that, as Olga said, that how do we bring in men within the conversation, but also prioritizing women? First, we encourage organizations. For example, the one I was working with in this research were able to adopt gender transformative approaches, where we see that all the interventions and the programs surrounding sexual reproductive health and involvement of men looks at creating opportunities for individuals, not only men, but also women, to actively challenge the gender norms. For example, not all gender norms are harmful, but then we look at the toxic masculinity which has dominated which has led to men dominating everything in decision making, access to services, even like ownership of property, where some of the women don't even have the fallback position, so they even don't have a say on how many children to bear and the rest. So within this, we look at promoting positions of social political influence for women in communities like those, and also addressing the power inequalities between the persons of the different genders. Then secondly, we looked at having projects where we train the male adolescents, offering them positive role models, like we had gender champions who are basically men who could talk to them how you can still make a decision with your wife in future, with your girlfriend, not only you making the decision as the head of the family, etc. Then another thing, we looked at engaging men in debates, mobilization, or forming new networks in the villages, where we worked with the parish leaders, with the chiefs and the other local leaders in talking about the toxic masculinities and how we can do away with them, but also looking at them working with their women in the community, sisters, mothers, their wives, and encouraging them to go together maybe for checkup, like during the accessing the antenatal services. There should not be only the woman to bother herself to only go, but also the man, because they're part of the decision makers in the family. But then prior to what she re-echoed in her question or statement, that we have seen that in Uganda, the Ministry of Health, together with other donors, for example, I was working on a 5-year program with one of the consultancy firms, but with funding from World Bank. And then we're implementing result-based frameworks in 56 districts in Uganda, and Tororo was one of them. But then for women to access the antenatal services and the rest, they were encouraged to go with their spouse, mostly the men, because they wanted to integrate in where men can also support the women, not only the woman to go through the whole system until when she gives birth. But then I agree with her that in that most of the men didn't even have time for that. They were like, we are working. Since the woman sits at home, she has to take care of that. That is her duty. But then prior to our program of male engagement, we have gone into having community dialogues with the men and the women. Then we have also encouraged couple counseling, then couple decision making, so that in case they have come maybe for testing for HIV, STDs and the rest, we also launch sexual reproductive services to them. Thank you. Then I also want to agree with one of the attendees who asked, and was that she re-echoed and said that women can't access contraceptives even if they want to, because male partners say no. Yes, it's true, most of them, because they're not well educated, they've not been able to access education services or go out and are able to learn that a woman can be empowered, she can have her own agency, she can make her own decision, she can say no to certain things and she can say yes to certain things. So most of them, because they don't have a fallback position, they're able to agree to what the man has commanded in the house, because they don't have anywhere to go, because the man has said this, he paid for my dowry, there is no way I can get out of this marriage. So most of them are able to continue giving birth, not because they want, but because they don't have a voice in the family. So it still goes back to the gender transformative approaches that we are trying to launch into this programming of male engagement, not only in sexual reproductive health, but also like in curbing gender-based violence on women and girls in our society. Thank you very much.
Brilliant. Thank you so much, Doreen. And I feel like we can really start to round up. I see that we are at the end of our session. It feels time's gone so fast and it's been so short, but it's been incredibly insightful. And I would like to thank our 3 researchers so much for doing the research that they've done. It's been incredibly powerful, and again highlights just the number of gaps really that exist in SRHR and the research we still have to do. So thank you so much. Also a big thank you to Olgah for being here and for posing really
I still see other people moving, so I think it's Nicole, right? That her internet stopped. Yeah, I think to finish Nicole's sentence, and maybe she will come back in. Thanks so much for everybody to be here, for being here, to Olgah for your valuable words. And yeah, please reach out also to the discussants who have shared their contact information in their presentations. And yeah, there is still a networking event after this session. So if you still feel energized to talk to other people, there was already one during lunchtime. So I will share also the link in the chat. Please feel free to still join and yeah, use this opportunity to network and extend your network and talk to like-minded young professionals and organizations. I see Nicole is coming back. But I think we can leave it with that. And then I would like to wish everybody a very nice day. Nice, Nicole, that you could come back for a second to wave.